Thank you very much indeed for the invitation. So, I'm going to talk about small molecules in ulcerative colitis. These are my disclosures. Now, small molecules are something that are kind of new to us in IBD, but they're kind of not new as well, because of course we've been using a small molecule for a long time. It's called azathioprine. But we kind of don't include that in this basket that has been created since the advent of the small molecules as advanced therapies, if you like. And they're different to biologics, okay? They're not the same. Biologics are specifically targeted antibodies. They have differences in the characteristics of how they work, so efficacy is not really quite related to exposure, at least once you get beyond a certain low level. Efficacy probably therefore doesn't always correlate with dose, and the off-target effects are somewhat limited and often irrespective of dose. We don't tend to overdose with biologics. Now, small molecules are different, and their ability to be very targeted is less good. They're a bit more selective in the way they approach, and actually once you start increasing the dose, they can become less selective. And so that's important when we're thinking about side effects, but it's also important to remember that as you up the dose, then you also tend to get increased efficacy as well, and we shall see that. So let's start with JAK inhibitors. Because I've got quite a lot of slides to get through, I'm not going to run through the mechanism of action other than to say that it affects the JAK-STAT pathway, which is a very important pathway throughout a whole range of inflammatory disorders. And I will very briefly mention that there are several JAKs. There's JAK1, 2, and 3, and TYK2. And that they work often in combinations of 2 or 3, and that those combinations are important in different receptors. So depending on which JAK you're inhibiting, so you will get different effects on different parts of the inflammatory pathway. And as I've just said, some JAKs are probably a little bit more selective than others as well. So for example, tofacitinib tends to target JAK1 and JAK3, but is really a pan-JAK inhibitor, whereas upadacitinib and filgotinib tend to target JAK1 a bit more. But remember, as I said, as you up the dose, that selectivity for individual JAKs becomes less apparent. They tend to sort of have off-target effects more. So, I'm going to ask a series of questions to try and guide us through this. And the first is a very simple question: does JAK inhibition work in ulcerative colitis? And the answer to that clearly is yes. These are the registration trials of the 3 JAK inhibitors. Octave, that's tofacitinib. Selection is filgotinib. And you achieve and you accomplish, of course, upadacitinib. And these are the induction data: week 8 for tofacitinib, 10 for filgo, and 8 for upadacitinib. And you can see that across the different trials, JAK inhibition is better than placebo, with the exception of the lower dose of filgotinib, 100 milligrams, which was not statistically significant. That aside, it's clear that these JAK inhibitors work, and it's certainly, if you look over at the right-hand side there at upadacitinib, you're starting to see deltas of approaching 30% in one of the studies. Just for induction, remember, induction of remission. This isn't for response. This is putting people in remission in 8 to 10 weeks. And of course, it won't surprise you to know that when you re-randomize these responders to either ongoing therapy with the JAK inhibitor or to withdraw back to placebo, then they tend to do better staying on the drug, again with the exception of filgotinib at 100 milligram, at the 100 milligram dose, where it didn't reach statistical significance. Okay, so they induce and they maintain remission. Let's just think about who these patients are in the trials. Well, they're a tricky group of patients. You can see that half of them have failed TNF inhibitors, and most of them have also been exposed to immunosuppressants and corticosteroids. This is the tofacitinib cohort. If we then go on to the upadacitinib cohort. Again, half of patients exposed to anti-TNF, but also you will see here a significant number, about a quarter, also exposed to vedolizumab. So this is a refractory treatment cohort. And that's important because, as I alluded to earlier today, in general, when patients have failed biologics, they don't tend to do as well on a second biologic. This is probably slightly less apparent when we look at JAK inhibitors. And again, on the left-hand side here, you have the patients who have basically not responded or lost response to a biologic. On the right-hand side, you have patients who haven't lost response to a biologic. And you see the deltas are not vastly different here when you look at the patients who are in remission or response in induction. So perhaps less of a disadvantage having failed to respond to a biologic before when we're thinking about JAK inhibitors. And I'll just flip past there. And then the final thing I want to talk about in terms of do JAK inhibitors work is lots of trial data there, and of course trial data is important and impressive, but what about the real world? These are some data that we put together from our early experience of using tofacitinib, and you'll see this is 3 years old now. And of course, when we were treating these tofacitinib patients, they were a very refractory cohort. Pretty much 100% of them had failed biologics. Most of them failed more than one biologic. And yes, in real life, when we're looking at remission and response and corticosteroid-free remission, you will see that we are reaching those sorts of endpoints and possibly even a little bit more than we see in the clinical trials. So, do JAK inhibitors work in ulcerative colitis? Yes, they both induce and maintain remission. Yes, they work in naive to biologics and refractory to biologic patients. And yes, they work in trials and in real life. Now, part of the title of this talk was about safety, so let's address that in a minute, because in fact, I'm just quickly going to talk about how quickly JAK inhibitors work. And I'm going to go through this quickly because there's a very simple message here. I'm going to show you these data. This is from the tofacitinib trials, and you can see here that there's a separation looking on the left at stool frequency and on the right at rectal bleeding by about day 3 in patients receiving placebo and patients receiving tofacitinib. And if you look for upadacitinib at the same data, then you can see a separation by day 1. These are very fast-acting drugs. Those of you who've used tofacitinib over the past few years will be aware of this, and those of you who've started to get access to upadacitinib, which is just about penetrating the region, will also be aware. Very fast-acting drug. And I could have shown you data for filgotinib as well. But that raises a possibility of thinking about using them without steroids. Now, of course, they do work in combination with steroids. And here is some data from the upadacitinib studies to show you that it doesn't matter whether you've got steroids on board or not. The drugs still work. But there's an important caveat here, and this relates to safety. If you look at the upadacitinib trial patients, and you look at the patients who have received steroids and upadacitinib for induction, then you'll see in terms of infection risk was higher in the patients on both of them. So that's important because A, we don't want to get give our patients infections, but B, there's perhaps a possibility here, because the drugs work so quickly, to skip steroids. Okay, they're really useful induction agents, but if we've got a drug that's working just as fast of them, and we don't need to be using steroids, then we have an opportunity to use JAK inhibitors instead of steroids. Important outcomes to look at, of course, not only include clinical symptoms, but the mucosa as well. And I'll just flick through some mucosal healing data for you here. So this is induction. This is mucosal healing, which is a Mayo endoscopic score of 0 or 1 for tofacitinib. And again, you can see here that by week 8, you've got about twice as many patients who've reached mucosal healing with induction therapy with tofacitinib than you do with placebo. And you can see that that's slightly greater, perhaps, in the non-TNF failed group, although not dramatically so. Those deltas are not that dissimilar to each other. And of course, when you look long term, and again, I'm showing you across all the different studies here, if you look in the long term, then you create mucosal healing. And those hashed bars there, that's by this bit of mucosal healing, we mean a Mayo endoscopic a score of 0 or 1, and the solid bar is 0. So that's complete mucosal healing, complete normalization of the mucosa. And again, I'll take you over to the right-hand side of the graphs here. Look at these upadacitinib data. You can see that on the 30 milligram dose, 60% of the patients have an endoscopic score of 0 or 1, with about a quarter of the patients with an endoscopic score of 0. That's pretty impressive, I think, in the context of clinical trials and comparing with the other therapies. And of course, they can go beyond mucosal healing and cause histological healing as well. An endpoint that we know is associated with a decreased chance of relapse over time. So, do JAK inhibitors heal the mucosa? Yes, they do, both in induction and maintenance. Yes, they can cause Mayo 1 healing, but they can also cause Mayo 0 healing. Yes, they do it in biologic-naive patients and biologic-refractory patients. And yes, they don't just cause endoscopic healing, but they cause histologic healing as well. So, I alluded earlier to doses, and I think we have to just think about that a little bit, because we know that there are different doses available for tofacitinib, 10 milligrams as induction and 5 or 10 as maintenance. Likewise for upadacitinib, the induction dose is 45 milligrams, and then the maintenance dose is either 15 or 30. Filgotinib, one tends to stick to the 200 dose. So is a higher dose better? Well, the answer to that is yes, it probably is a bit. Again, here we see the tofacitinib data, and you can see that in maintenance, your chance of being in remission is a little bit higher in the patients who are on 10 milligrams twice a day, and the chance of achieving mucosal healing is a bit higher with 10 milligrams twice a day. Filgotinib, not surprisingly, given the fact that the 100 dose wasn't effective compared to placebo in the clinical trials. Again, we see here that the higher dose is more effective. And then finally with the upadacitinib, again, you see there's a little bit of an extra boost there in the patients who are on the 30 dose rather than the 15 dose. So if you look into the trials, you can see that the patients who benefit from the higher dose are the patients who have more refractory disease. And this shouldn't be surprising to us. Okay, so there's patients who fail biologics, who take longer time to get into remission. These are the ones who tend to do better on the higher dose. And I would say that absolutely reflects our clinical practice as well. When we've got those more refractory patients, they will often take longer to get into a really good remission, and they're more likely to relapse when you bring the dose down to the lower dose. But that's the beauty of JAK inhibitors. You can flip between the two doses as needed. So, are higher doses of JAK inhibitors more effective? Yes, they are. A dose response is seen as expected, maybe more so for the harder endpoints, such as mucosal healing and histological healing, and maybe more so for the more refractory patients as well. Here is this like fly in the ointment. Do JAK inhibitors cause serious side effects? Many of you will know about the signal for herpes zoster, and indeed, if you look in the clinical trials, we see it there. Here we see the upadacitinib data, and perhaps not surprisingly, in maintenance, more patients who were receiving upadacitinib developed herpes zoster than those who were receiving placebo. To be honest, this is a manageable risk. Most of the herpes zoster is not bad, and when you stop the drug, it gets better. And of course, now we have a non-live vaccine, the penetration of which around the world is slowly increasing. It's a little bit sluggish in many parts of the world, but we'll get there. And I think that once that's available to us, I think this becomes a much lesser issue. But you will also have heard about the risk of more serious side effects such as venous thromboembolism, cardiovascular side effects, and death in people from this trial, the oral surveillance study. we have to remind ourselves about some things in relation to this study. These were a group of patients who were over the age of 50, had cardiovascular risk factors, they had rheumatoid arthritis, not ulcerative colitis or Crohn's disease, and they were all on methotrexate as well. And yes, when you used a higher dose of tofacitinib in these patients, you started to see a signal that there were some more serious outcomes. But how does that really translate to our patients with ulcerative colitis? And indeed, how does it translate outside the context of tofacitinib to upadacitinib and to filgotinib? Well, I think the first important message here is that if you actually look at the risk of getting a DVT or a PE in the clinical trial program for tofacitinib, and you look in the induction and the maintenance part of the program, the only DVTs and PEs that you see are in the placebo arm. And that's, I think, the most important message here. The biggest risk factor for DVT and PE in inflammatory bowel disease is active inflammatory bowel disease. And the best way, therefore, to prevent it is to treat the disease. And in fact, in the induction maintenance arms, there were no DVTs or PEs in the tofacitinib group. There were some seen in the open label extension part of the study, but they were all in patients with risk factors. And I think in reality, there's been a lot of damage done to patients with ulcerative colitis by the oral surveillance study because people have been scared of using JAK inhibitors in a group of patients who would have benefited from it. And indeed, when you look at in real-world cohorts, and because I'm running a bit short of time, I maybe won't go through this in too much detail, but this group of 400 patients from Spain included a whole load of patients who had cardiovascular and thrombotic risk factors. 30% of the patients in this cohort had risk factors, and then I'll just go through to the results. And then you did see a bit of zoster, and of course you will see a bit of infections. But in fact, the risk of cardiovascular events and the risk of DVTs and PEs is probably exactly what you'd expect at background in these patients here. So I think this risk has been overstated, and whilst we should probably avoid these drugs in some patients, we shouldn't overread the safety signals. So do JAK inhibitors cause serious side effects? Yes, they do, but so do other drugs. So importantly does active IBD, and of course it's possible to mitigate against these risks and keep them in context. So to finish off, I'm going to talk about the other class of small molecules. That's the S1P receptor modulators. That's ozanimod and etrasimod. And let's ask ourselves some similar questions. Do they work in ulcerative colitis? Well, yes. Here are the induction data at week 10 for ozanimod in patients with moderate to severe UC. And you can see, if you look on the left-hand side there, a delta over placebo of about 12%. And you look at some of the other outcomes, including endoscopic and mucosal healing. Again, we see improvement there. And then if we go to maintenance, again, across both clinical endpoints, mucosal endpoints, and histological endpoints, again, we see benefit of drug over placebo. And we don't just see it for ozanimod, but we also see it in etrasimod as well. One thing when you're looking at these studies is to remember that the etrasimod trials are slightly different. First time we've seen a treat-through trial for quite a long time in inflammatory bowel disease, but it reminds us that we have to be very careful when we're comparing endpoints. But again, etrasimod at weeks 12 and week 52, better than placebo in terms of inducing clinical remission, but also in terms of endoscopic improvement and mucosal healing. So clearly, we have evidence that the drugs work in induction and maintenance. Now, I said that with JAK inhibition, perhaps the effect of previous biologic exposure was a little bit less obvious. Well, certainly in induction, if you look on the left-hand side here, this is patients who were in the ozanimod study divided by whether they were biologic naive, they'd received one biologic, or they'd received two biologics. You can see there does appear to be a pretty significant effect here of previous biologic exposure. Now, I wonder if that's simply that these patients take longer to get into remission rather than that the drug really doesn't work. And indeed, when you look at extended induction, you certainly do capture some more patients. I think the other thing that perhaps slightly supports that is if you go over to the maintenance arm on the right-hand side there, you'll see that the deltas here actually are not that different depending on when you divide them by biologic experienced or non-experienced. So if you do respond to the drug, it doesn't really matter how many biologics have been exposed to in the past, but it just either you don't respond as well and or you take longer to respond if you've been exposed to biologics. So do S1P receptor modulators work in ulcerative colitis? Well, yes, they do in both induction and maintenance. They work in naive patients, perhaps slightly less well in refractory patients, although I think we need to understand that more, and they improve symptoms in the mucosa. And then finally, what about side effects of S1P receptor modulators? Well, in fact, I think it's fair to say that the side effect profile, if you look in the clinical studies, is actually quite favorable. You absolutely get a drop in the lymphocyte count, and that's because of the mechanism of action, but that's not associated with a great increase in risk of serious infections. You do see a little bit of liver function abnormality as well, although that often gets better with time, and you will have seen I put a sort of bradycardia slide up there. To be honest, if you have patients who don't have conduction defects, who we tend to screen out with ECGs before starting, then I think actually the chance of having significant bradycardia is extremely small indeed. In the trials, the average decrease in the pulse rate in patients receiving drug was 1 beat per minute. So I think, again, it's something that one has to keep in context. And then finally, I'm just going to talk very briefly about how we choose between the drugs. And Rima has actually talked a little bit about this already, concentrating on the biologics, and he's talked about network meta-analysis. This is the one that came out first, which included the upadacitinib data, and it showed, perhaps not surprisingly, that upadacitinib performs extremely well in induction in network meta-analysis. I think there are some caveats to this. The first is, of course, that we have to remember we're dealing with different trials, different patient cohorts, different time points of induction. And the second thing you have to remember is, of course, that if you're looking at an induction network meta-analysis, then it's going to favor drugs that work more quickly, whereas drugs that take longer to work are not going to perform so well. So I think we have to take that with a pinch of salt. And of course, as Remo rightly pointed out, we can't just think about network meta-analysis, but we need to think about head-to-head trials. We need to think about real-world data, and we can't help but be influenced by our own experience. So, apologies for going a couple of minutes over time, but I'm going to conclude by saying that I think that small molecules represent a really important addition to our medical options. And when you look at some of the data, the efficacy data there, I think it's fantastic that we now have access to these. And so do our patients, because let's not forget, many of them actually prefer to take tablets rather than infusions or injections. And like all drugs, yes, they have side effects, but I think those side effects are both acceptable and manageable as long as we use them sensibly and in the right patients. Thank you very much.